Broadcasting from the historic Hayburn Building in downtown Louisville, it's time for Single Payer Radio, a project of Kentuckians for Single Payer Healthcare. We are an affiliate of the Kentucky chapter of Physicians for a National Health Program, and we're a long-standing community partner with Forward Radio. We invite you also to get your group to join Forward Radio as a community partner. I'm Mark McKinley, a volunteer with the group. The views and opinions expressed on the show are those of the speakers and not the station. And speaking of the station, Forward Radio is Louisville's all-volunteer, progressive community radio station, and we're a Pacifica affiliate. Join us. And before we get into the show, first a reminder to get your marching shoes on. Louisville and 33 other cities across the country will march for Medicare for All this Saturday morning, July 24th. We'll start at 11 a.m. We're going to meet down at the Mazzoli Federal Building there at 7th and Chestnut. There will be a few speakers, some music, refreshments. We're going to celebrate Medicare's 56th birthday. Please join us. And for more information about that march and other info from Kentuckians for Single Payer Healthcare, go to kyhealthcare.org or check us out on Facebook. Now, we'll be joined by Drs. Mike Flynn, Gene Shavley. Dr. Flynn?
Mark, nice to be here. Good to see you again. Let me begin with the first disclaimer that any comments I made or views I express here represent my personal views and do not represent the views of the University of Louisville or the Department of Surgery.
My comments are my personal views and do not represent the Taylor Regional Hospital nor the University of Louisville. And I also want to caution you that what we say may not be actual facts because this whole subject is extremely complicated and it changes frequently and it's different in different states. So, and in my studying of this, I sometimes became very, very confused about what's what. But anyway, we're going to attempt to discuss Medicaid and try to give you an overview of what Medicaid's for and at least how it's helping the state of Kentucky. There are some states that did not go with the Medicaid expansion, and they have a lot of citizens who are not covered. Medicaid was actually created the same year that Medicare was created in 1965. Lyndon Baines Johnson, it was his project. Johnson, contrary to some opinion, really had a heart for integration and racial justice and for the poor. And that all started in Texas when he finished college and was teaching in a small town where there were a lot of poor people. And I remember in 1965 they had a picture of him in eastern Kentucky sitting on a porch in a rocking chair, and that's when Medicare started. Now, Medicare is different than Medicaid. They were both started at the same time, but Medicare was started for the elderly, those 65 and above, and it was kind of an old age insurance policy. Now, you got to remember that a lot of people didn't make it to age 65 in those days, so it was kind of easy to pay for it. Medicaid, on the other hand, was started for low-income people below a certain level. And right now, it's 133% of the federal poverty level, and it includes adults, children, pregnant women, the elderly, adults, and people with severe disabilities. It's interesting that half of the deliveries in the United States are covered by Medicaid. Medicaid is administered by the states, but the federal government has rules that you have to follow, but each state is different, and that makes it very difficult to follow. It depends on which state you're in. And there are approximately 74 million people who are covered under Medicaid. I've seen numbers up to 85 million, but it's a significant number of people who are now covered by Medicaid. The states are responsible for administering the program, and they can actually make up some of their own rules, and they can go after different waivers. The federal government has different waivers. For example, in the last administration, there was a plan that if anyone was able-bodied, that they had to work or be going to college or some type of school in order to be eligible for Medicaid. Another interesting thing that's happened in the last few years with the Medicaid expansion, we now have good evidence that it's increased the health of the people who are on Medicaid. And the University of Louisville and the University of Kentucky have done studies that show that patients who need colonoscopy for prevention of colon cancer and patients who need mammograms for prevention of breast cancer, that since the expansion of Medicaid, the actual death rate from colon cancer and breast cancer has gone down, and we picked up these type of cancers in an earlier stage. The federal government matches most of the money. It also depends on which state you're in, but the minimum is 50% and the maximum is 83%. Again, I'm not 100% sure of this, but I think, and we're going to have to get some more expertise on this, but I think that number is going to go up to 90%. Mike, do you know any information about how much the federal government is going to put into Medicaid?
Yeah, Gene, let me make that. I want to make a second disclaimer before making any more comments. This, as you've mentioned, and I agree, this is incredibly complicated. And I was in clinical practice, private practice, and academics for over 50 years. And, this started in 1965, and I started in 1971. And through all that time, I really never had to deal with Medicaid. I knew it was there. I knew that we had patients that came into whichever practice I happened to be in at the time, but there was always somebody in the office that managed all this. And when I started to, as you mentioned, started to look up the stuff that we were learning about this, the complexity is remarkable. So the disclaimer is, and I would challenge any listeners, as you've said earlier, we may not have all the facts, and that if we say something or I say something that doesn't seem to make sense or somebody disagree with me, I would challenge you to go to an assortment of really good references and just get a look into the references and decide for yourselves. So. And let me just, a couple of examples. I mean, you can go to Medicaid.gov, benefits.gov. Kaiser Health News is a good organization. It is not part of Kaiser Permanente, a subsidiary. It's a separate organization. And I learned a lot from getting on my computer and getting on Firefox or Google and just putting in Medicaid podcasts. And one of the better ones was a podcast called Mostly Medicaid. So having having gotten that out of the way I understand the funding is that the federal government provides a certain amount of funds, and they also have a set of rules, guidelines, standards that the states have to comply with. And having done that, then the states have a huge amount of latitude to do sort of manage the programs within those guidelines. So my understanding is the states just can't do whatever they want to do. They have a lot of flexibility within the federal guidelines, which I had a little trouble figuring out. According to Kaiser Health News, in November 2020, under the Affordable Care Act, the federal government pays 90% of the newly enrolled recipients. And under traditional Medicaid, the federal government pays about 2/3 of the cost. So, again, that's the best understanding I have of how the funding works. And I agree with you. I think hopefully at some point we may be able to get a hold of someone who deals with this in a more detailed way than we have and get some hard information about that, how that works.
The program is the largest funding for people who are in the low-income area, individuals and families. The total spending in 2019 was $614 billion, and the federal government is responsible for about 65%, and the states about 35%. Again, depending on which state and what if you've extended Medicaid expansion in your state or not.
And states have the option of spending more. I mean,
Right.
they're not limited in what they spend. So, and I wasn't able to. I didn't have time to. You can get on one of these websites and go through every state in the union and what their Medicare eligibility, funding, coverage, and all those other issues are. So there's a lot of variability.
Those who are usually eligible are under age 65. I don't know what's going to happen under the current president's proposal to expand Medicare down to age 60. But I suspect that those who will be eligible for Medicaid will be under age 60. You have to be under 133% of the poverty level, which is not very much money. Children represent about 38% of the enrollees, and those with disabilities about 14%, which represents about 36% of the total cost.
As you mentioned earlier, coverage is there are 71 million. I guess these numbers change depending upon whenever they're taken. In the U.S. includes children, pregnant women, parents, seniors, and folks with disabilities. And there's also different eligibility issues in different states, which is what really makes it kind of confusing. Kentucky, you have to be a Kentucky resident, U.S. citizen. You can be a legal, illegal, not illegal, legal alien in need of health care or in insurance assistance with financially low or very low income, pregnant, or responsible for an 18-year-old or younger, somebody with a disability or a family member with a disability or a low annual household income. And I've got this table in front of me. And so if you are a single household, then the maximum income level per year is $17,000 and change. If there's two of you, it goes up to $23,000 and change. Four of you, $35,000 and change. Six, $47,000 and change, and eight, $59,000 and change. So, you know, trying to figure all this stuff out, it's just fascinating. It's Kentucky. I haven't even got to Massachusetts or Rhode Island or Texas or Georgia. So.
It also covers most indigent patients in the nursing homes. If you're totally disabled and have to go to the nursing home, Medicaid will cover you, but the income level is very low. It's if you're single, it's $2,382 a month. And you only get about $60 of spending money a month. So I doubt if any one of us could survive on $60 of spending.
What are you going to do with the money in the nursing home anyway? I mean, you going to buy some chocolate chip cookies? Or I don't know what the options are in a place like that. Medicaid expansion was an interesting activity initiated by the Affordable Care Act. And there were 39 states plus Washington, D.C. that expanded Medicaid. And 12 states did not. And the implementation again, it was different things in different states. Some had work requirements. One state raised a tobacco tax in order to pay for expanded services. Governor Beshear I implemented this in December of 2019. There was no work requirement, and if you remember when we had Dr. Voida and Ms. Casey from the Community Health Center in Phoenix talking about homeless, all the homeless population are covered. I'm assuming that they only deal with Louisville, but I'm assuming that that's true throughout the state. It's not something could figure out any way to verify. So. I mean, this was a good thing you mentioned earlier, and so there's an assortment of coverage that ranges from adults from 19 to 64, nursing home residents, disabilities, and Medicare beneficiaries in nursing home or undergoing in need of personal care services. And again, just to recognize the limitations of some of the things that we've talked about, I really just had a mind-bending time trying to figure out who decides how who gets covered with what, and because there are all kinds of waivers and other aspects of this that have made it probably one of the most complicated things that we've ever had to decided to talk about or discuss here.
Well, you mentioned earlier during your practice and mine too that we never had to get involved in this, and I think as a physician that you only got 24 hours in a day, and that you've got to let other people do these kind of things. There's no way that physicians can be involved in all the insurance and social aspects of medicine not only is it mind-boggling, but there's just not enough time to do that. And I think that's one of the things that patients need to understand is that we have to concentrate on the actual practice of medicine. The practice of medicine has become so very complicated that most of us have to just emphasize our specialty.
And I've got a map in front of me. I'm looking at this map that shows the different states that expanded Medicare and the ones that haven't. So
Is that Medicaid or Medicaid?
I'm sorry. Yes,
Okay.
Mark. Thank you. Got a little bit of a brain thing here. Starting from the top, so we got, again, Medicaid expansion. Wisconsin, South Dakota, and Wyoming did not. Kansas did not. Missouri has adopted it, but it hasn't implemented it, and I'm not sure how that. Texas and the South, basically North, South Carolina, Georgia, Alabama, Mississippi, and Florida. And I don't know how much this is related to Medicaid issues as much as it is ideology, but many of these states are the states where they're seeing surges of COVID now because they have a very high unvaccinated populations.
Well, if you live in those states and you're between the ages of 21 and 65 and you're below the poverty level, then you cannot get insurance. I mean, you can't afford private insurance, and Medicaid's cannot cover you. So if you get COVID and and you're not vaccinated, then you're in a bad situation. You'll have to go to the hospital, a government hospital, a university hospital that will take care of you. That creates a problem that I don't think is acceptable in our society now.
Well, it's a double whammy in the sense, on one hand, you've got these political and ideological beliefs that vaccinations, for an assortment of different reasons, people shouldn't be taking them. I know this is not what we're supposed to be talking about, but I had my haircut the other day, and the barber was telling me that there are some relatives that have refused to get vaccinated because they're concerned that with the vaccination, the government is going to put some kind of a device in them so they can be tracked. And I'm looking at my cell phone. Anybody wants to track you, all I have to do is look at your cell phone. So
that's what I was thinking about, your cell phone.
Well, anyhow, now let me. There different states have done different things, and as I was kind of scrolling through all the different activities of the different states and I don't know when. During the Trump administration, the state of Georgia privatized Medicaid. And so I was trying to figure out how did this, so what they did, apparently now they allow private health insurance companies to administer the state Medicaid program. And I guess that's what the other states are doing in kind of different ways. They used to have a website where the website we've had here, and there's healthcare.gov, where an individual could go to a single site to determine eligibility issues, which, as we've already discussed in some vague way, can be really very very complicated. So this website was taken down, and each of the insurance companies then set up a separate site with a specific program offering, and the programs that they offered were all different. And so you had this already complicated process where you could go to one website and try to navigate your way through all of the eligibility issues of your income status, your disability status, whether there was 6 or 3 or 2 members of your family, who's pregnant, and all of these other issues. And that process is now incredibly more complicated because it's gone. And to try to figure out how to get from one website to the other website to the other website, and if you think about it, many of the people in the Medicaid population are older. They're if they have computers at all, their computer skills are probably more basic than maybe some others. And it's just an amazing example of how, at least in my opinion, not to manage a program like this that's trying to provide health care.
Well, you mentioned managed, and in 1980, the federal government started allowing Medicaid go to managed care, and now I think most of the Medicaid programs are under managed care, and the state of Kentucky is. And I don't know exactly how that works. I know that it's been bid twice, and it's now in court again over how they bid it. But it's my understanding that the state of Kentucky doesn't really run the Medicaid. They contract it out with a for-profit company who manages it, and the state gives them money to manage them. So we are now seeing private insurance companies getting into Medicaid, and I've got an article here that says that Medicaid insurance ensures a growing competitive force in the ACA marketplace, and the Medicaid managed care are becoming more and more competitive with other insurance. So this could be a good thing in that we have Medicaid managed care competing with other private insurance. And another article I read said that the cost of insurance was going down, and that the Medicaid managed care was doing a good job and charging less than the other not-for-profits. So I think one of our goals should be, if we get an expert to come to talk to us about this and tell us how this works and how is the marketplace playing out in this issue.
No, I agreed. I want to read something that I got off one of the websites that I looked at. And I wanted to bang my head against the wall after I was reading this and maybe see what you think. Okay, it says here, Medicaid managed care organizations, parentheses, MCOs, close parentheses, provide comprehensive acute care and, in some cases, long-term services and supports to Medicaid beneficiaries. MCOs accept a set per member per month payment for these services and are at financial risks for the Medicare services specified in the contracts. Do you have any idea what that means? I mean, it sounds to me like they a set per member per month payment. Now, presumably that's coming from the federal government, the state government, and then they supposedly are at financial risk. I don't know what I just don't know what this means.
Well, I do know they're at financial risk because I know there was a company several years ago in Florida that went bankrupt because they couldn't meet the needs of their Medicaid patients.
So these Medicaid managed care organizations, the states, the federal government funds whatever amount that they fund. I think we said it's somewhere between 90% and 65%. The states administer and design these Medicaid programs within the federal rules or the federal guidelines. And the information that I was looking at, as of July of 2019, there are 40 states and Washington, D.C. that contract with comprehensive risk-based managed care organizations to provide care. And not exactly sure what that meant. So when I looked on a little further, a different website indicated that there are 17, and this is 2018, and I'm not sure what the situation is today. This is some years ago. 17 managed care organizations. They were non-profit, for-profit, and government-run. 6 of the for-profits were United Health, Centene, an organization that I've not heard of before, Anthem, Molina, another organization that I haven't heard from. These are all for-profit health companies or managed care organizations, Aetna and WellCare. And in 39 of these managed care organization states, there are Fortune 500 companies in this Medicare organization Medicaid market. So you're absolutely right. We've reached a situation where Wall Street has gotten into another supposed health coverage program for the disabled and the poor. And my question is, what do they get out of it? And I can't find that out. What is the benefit of United, Anthem, and Aetna? Because these people aren't doing this for humanitarian reasons. They don't provide health care. They are selling insurance policies and then trying to figure out how to keep as much of the money and not providing health care.
Well, the answer to your question is money.
No, I understand, but how does that work? We talked about this earlier. When I was a faculty member at the University of Louisville, the U of L was self-insured, and they would design the program, they would fund the program, and then they would contract with a health insurance company to administer it, and they paid them a fee. We talked in one of an earlier programs about hedge funds managing nursing homes. It's a different situation. A hedge fund buys a nursing home chain. They want to get return on investment of 10, 15, 20% over 2, 3, or 4 years, and then try to sell it and move on to something else. So I can't figure out how or why these for-profit companies. I know money's the issue, but how do they get it?
Now, I don't know exactly how they get it, but I can tell you that Centene is almost all their work is in Medicaid. They started off that way. They've expanded a little more in private insurance, and Molina is the same way. Centene has even gotten into the healthcare market in Spain and England in certain aspects. I don't think they really want you to know how they do that.
Well, of course they don't. But, that's what you'd like to know. How do they? What's the process? I know what the process was with U of L, in the way that program worked. And U of L was also self-insured when it came to medical liability insurance for the same reasons.
Well, let me just read to you 3 headlines here.
All right.
Expanding Medicaid creates significant business opportunities for insurers operating Medicaid managed care plans. Number 2, expanding Medicaid would result in lower coverage costs and more stable private insurance market, which would benefit insurers who are only participating in the private market. And 3, Medicaid expansion would allow insurance to better manage care effectively and efficiently.
Now, that this doesn't make sense because these people are not into it to provide health care. I mean, we've talked about for-profit insurance companies on 2 or 3 occasions, and the goal is very clear. Their goal is to use all money for all sorts of reasons, from overpaid CEOs to buying off politicians to advertising, and the end of the day, at the end of the day, actually paying for health care is called the medical loss ratio. From a business standpoint, this is a financial loss to be paying for the product that you're selling. And so I don't know how the market is going to benefit the Medicaid market, which is supposed to be a government-funded program to provide health care for people with low-income disabilities and who can't afford, or people with Medicare who need to be in nursing homes and don't need to spend every dime they've got, in the last few years of their lives. So how does that work?
Well, I don't know, because as you well know, that most Medicaid patients are very sick.
Yeah.
It also includes the mentally ill, and how you make money off that is something that we need to look into on our next broadcast on this subject, because they're doing it, but they have to be rationing or providing decreased care in some way. Are they doing actuarials on patients? And are they selecting out certain patients that they're going to insure, they're not going to insure? I don't think they can do that under Medicaid regulations. But they're doing it somehow, and more insurance companies becoming really interested.
The federal funding, one of the federal funding rules, guidelines, standards, whatever you want to call them, is budget neutrality. So that the federal government won't spend any more money. The state can design whatever plan it wants. So the only way that I can rationalize that these for-profit insurance companies can make any money is by not providing care. Now, they may not provide care by reducing the services. It may affect the timing of the services. It may affect the eligibility. But there's just no, this doesn't, this is a 2 and 2 makes 5 kind of equation. And unfortunately, I'm not smart enough, and I don't think you and I have got enough of the sort of technical know-how to figure out where it is. But there's got to be some explanation for why these companies are in this marketplace.
Well, guys, if you look at the Affordable Care Act and how that has been a real bonanza to private insurers, because it's the feds will subsidize much of the insurance premiums for folks who receive their insurance under the Affordable Care Act. And it's this is It's is
Isn't
it part of the same game that it's a guaranteed income stream?
I don't think it's guaranteed, but I think that's going on. They're subsidizing it, and if they start losing money, they're putting more money into it.
No, wait. Tell me that again. I'm still. I'm not
I
connecting
just like
it.
the ACA.
Yes, and I agree with Mark that. But the way I understood the funding process of Medicaid is the federal government's portion. One of the aspects of it is eligibility. It has to be for low-income people, for disabilities, and there's a number of other categories. The other component of it was coverage. You had to cover enough certain things. These were the federal government's guidelines or standards. And I can't remember. There's another one in there, and then there is budget neutral, so that if the government is spending, I think I mentioned earlier that it was that 90% of the new signing on under the ACA, expanded ACA, was covered by the federal government, and the traditional Medicaid, it's about 65%. So then it doesn't add up. Because if it's budget neutral, it's got to be budget neutral. So it means that there's no more money coming in. They have to figure out ways not, which is what they do, is to not spend the money they're getting on health care. And they're very good at that, because that's why they've got so much money.
Well, I think under the ACA they are actually subsidizing some things. Is that true, Mark?
Now, we're talking about Medicaid, or have we gone past Medicaid now to something else, or we're still talking about Medicaid?
Well, just with the ACA, if a person is under a certain income, then the feds will pick up whatever the balance of the premium that's going to the private insurance company. The individual might be paying $100 a month, and the federal subsidy might be $500 a month.
Right.
So, Gene, getting back to what you were saying early on, the coverage, how many people are covered? The Center on Budget and Policy Priorities in April of 2020. They said that in 2018, 97 million low-income Americans are insured under the Medicaid program. I mean, 97 of, what are we, a country of like 360? I mean, hell, that's 1 out of every 4
Yes, that's true.
Americans are under Medicaid, and oh, hell yeah. The people are rubbing their hands together and saying, hey, we can make some money here.
Right. There's been other good things that have happened in Medicaid expansion.
Oh, for sure.
For example, a lot of rural hospitals are doing much better.
Definitely.
A lot of hospitals that take care of poor people, like the University Hospital, are doing much better. And there are other things that Medicaid covers that we don't think about. For example, if you have a child that's disabled and needs physical therapy or speech therapy or special care, Medicaid will reimburse the school system for that. They also pay for daycare and people who have special needs. They pay for individual housing. Of course, the trend now is to put people who have brain injuries or other mental issues in private housing, where someone stays with them 24/7, and they go to daycare in the daytime. Medicaid reimburses for all that. So it's really been a lot of good things that have coming out of
Well,
this.
I don't. There's no. I'm not questioning that. Again, the issue that I still don't figure out is this fundamental question of you've got these for-profit health insurance companies whose goal is to make as much money as possible,
Okay.
not necessarily providing health care. And so they sell insurance policies that can range from very expensive, very good policies to cheap policies that don't cover anything. You get sick, you go bankrupt, and then they use the money for an assortment of different things. We've talked about this a bunch of times, and then at the end of the day, the actual payment of the health coverage is considered a business loss, and you can jump through all the hoops of the pre-authorization and the extra pay, the coverages, the out-of-pocket expenses, yada. And again, I'm still trying to get my head around how the Medicaid marketplace is beneficial to the for-profit insurance companies. How? Because I've said this before, just a few minutes ago. The only way they seem to be able to do this is by not paying for health coverage.
Well, I think right now the states are putting more money into it than the federal government is. I think the problem's going to be is that one of these days they're going to reach a saturation point, and particularly when equity companies get involved.
Well, they're already involved in these medical managed care organizations.
Right.
Medicaid managed care
Well, now,
organizations.
most of these are not equity companies like WellCare, the ones you just mentioned. They're not. But the equity companies are not regulated. They can go in and buy out like an anesthesia practice, and the anesthesiologists don't have much say. I read about a company that they fired all the anesthesiologists and hired nurse anesthetists. Another thing that can happen, they can buy a nursing home. They take out huge loans against that nursing home, and then they cut down on the quality of care. And after about 4 or 5 years, they try to sell it, and the stockholders will get that money that they borrowed, and the facility will end up owing the debt. So it's a very complicated system, and I think we got to be very careful how this is done.
Well, I hope that we can get someone who has enough specific knowledge of how these programs work to help me understand how this process of having a set of rules, budget neutrality, eligibility rules, coverage rules, established by the federal government, the sort of foundation, allowing states the flexibility to administer these programs. The state then hires Aetna, an organization designed to extract as much money out of the healthcare system as they possibly can to run this government-funded program to provide healthcare coverage for people who are with low income and disabled. It's this, I don't want to sound like a broken record, but I guess it's what it sounds like. It doesn't make sense. And these aren't equity companies buying a hospital or a clinical practice or a nursing home. These are supposedly working within the framework of the limitations of the federal government. And maybe you're right. Maybe the states are are ponying up more. I suspect that what's going on here is, if you can get into the details of it, they have figured out ways to either limit the cover. That's how they provide. That's what all their healthcare issues have to do with, either making people pay more than the premiums or not getting coverage.
Well, I know one thing they are doing, and that is they're really emphasizing outpatient care. That saves them a huge amount of money. And they are really emphasizing to primary care physicians to keep these patients out of the hospital. Most patients who are on Medicaid, who have diabetes or have hypertension, they're now being seen by their primary care physician every 3 months. And they don't just go in, when they're feeling bad like it used to be. They are required to go in and they check their sugars and they check their blood pressure, and they're required to follow up, and the purpose is to keep them out of the hospital.
I guess a question I have is, are these insurance companies beating down the providers, the doctors, and their practices on the reimbursement rates for Medicaid patients?
I don't know if that's true or not. I can tell you right now, what I've personally seen is that most of the patients seem to be very happy. The insurance companies are making great effort to make patients happy, and it seems like that the doctors are very happy. Most of the providers in South Central Kentucky, though, are nurse practitioners.
Okay, I just
See,
whether a practice will decide whether to take Medicaid patients or not because of reimbursement rates.
well, in the
I
past, most practices would not take Medicaid patients because of low reimbursement. I think that's changing a little bit, particularly with nurse practitioners, and particularly with mental health and also Suboxone clinics.
Now, when I was in private practice, which was I joined the university faculty in the mid '80s. This was before. I mean, the for-profits, health insurance companies, they broke out in the early '90s. So I had left that marketplace where I had to sit down and worry about, who was, how much money I was bringing in. I ended up in a practice with 40 other people. I didn't have to worry about not, whether my time was being well used on a Medicaid patient. I just treated everybody who walked in the door. I was really happy to be able to do that and not have to deal with those other things. And whatever I made in the course of a month, that's what I made. I had all of these. You have all these other activities of putting talks together, doing clinical research, and all of those other activities with national organizations. So, I didn't have that experience of having to struggle through the difference between the declining revenue from a Medicaid patient versus somebody who had private insurance.
Well, I can tell you that if you have, at least in the past, if you had too many Medicaid patients, you could not meet your overhead. And a lot of people would take so many Medicaid patients and then they would stop. And if you were a patient, like for example, I had this happen multiple times, and I think it's still going on. If a Medicaid patient came in and with an appendicitis and you operated on them, sometimes it was extremely difficult to find someone to take care of them as primary care because of the reimbursement.
Well, if you're a Medicaid patient looking to get a facelift somewhere or breast implants or something, from
Right,
a
that's
plastic
different.
surgeon, they don't even take private insurance, much less you got. I was in. I got to tell you a story. I did my general surgical residency at the University of Maryland, and the fellow who was a chief resident 2 years ahead of me, whose name I won't mention, went up to Michigan and did a plastic surgery residency, and then he went out to San Diego, and he established his practice. It was mostly in an outpatient facility, and he explained to me once that he was in this building, and there was a bank in the building. And he had worked out this arrangement with the bank, and so the people would come in and they'd want to do a facelift or a lip, some kind of get your nose shortened or lengthened or whatever you're going to do, or liposuction, whatever they were going to do, and then they would send them down to the bank and they would work out some sort of financing and he would have this done. I mean, this is just good. This is good business, but it didn't have anything to do with the practice of medicine, and so. If you're in one of those situations, that's what. I guess we don't have. I wanted to talk about Medicaid buy-in, but we're running short on time. I would suggest that this is part one of, I don't know whether it's going to be 2 or 3, but there's a lot of things to talk about here. There's a lot we don't know, and I would suggest that we. Maybe give it some time, see what we can do about finding some non-medical person, some administrative person who's got the skills to deal with these things and talk about this again.
I got one more point. I know of a hospital which will remain nameless who used to make patients with real medical problems go to the bank and borrow money before they would take them in and do elective surgery, etc., on significant problems.
Well, that's it. That's not a good point to end on, but that's where we are. Okay, Mark.
Thanks, Gene.
I'll be glad to loan you some money.
Let me skip on down to the bank before my appendix bursts. But hope to see everyone over at the Mazzoli Federal Building Saturday morning, 11 o'clock. Join us for the celebration for Medicare's 56th birthday. For more information about single-payer health care and some of this info, go to kyhealthcare.org. That's kyhealthcare.org. Guys, pretty interesting show. More to come.